Hello, guys. I hope you are doing well. Previously, we have discussed about the definition and the causes of intrauterine fetal death. In this video, we are going to discuss how to diagnose the intrauterine fetal death. So, there are some symptoms, some signs, some per abdominal examinations findings, and some investigations that are going to help us in diagnose the intrauterine fetal death. So, in symptoms, the patient came with the complaining of absent fetal movements which were previously noted by the patient. So this is a classic uh, complaint of the patient. The patient came with the complaining of decreased fetal movements or absent fetal movements which was previously normal felt by the patient. So what actually happened is many patients came to OPD with the decreased fetal movements or absent fetal movements, but they are not actually having the intrauterine fetal death. There are some other causes also of decreased fetal movements like sleeping phase of baby or polyhydramnios or some breech presentation in which there is also a decreased fetal movements perceived by the patient. What uh, signs we see during the examination is the retrogression of the breast changes that occur during the pregnancy is evident after variable period following the death of the fetus. So what happens is there are physiological changes in breast happening during pregnancy. So in case of the IUD, these breast changes are regressed. So this is one of the signs that we have to look for. So now moving on to the per abdominal examination, there are some uh, things that during examination we find in case of the intrauterine fetal death. So on inspection, we see a gradual retrogression of the fundal height. Sorry, it's written funnel, but it's fundal height, and it becomes the smaller than the period of gestation. So what actually normal happening is if the patient is around 28 week pregnant, so the fundal height correspond to that period of gestation. So in case of the intrauterine fetal death, the fundal height is not around 28 weeks, it is somewhat lesser than like around 26 weeks or 24 weeks due to non-developing fetus, and also some cases suggestive of oligohydramnios with associated IUD. So there is a gradual retrogression of the fundal height and it becomes smaller than the period of gestation. Second one is uterine tone. The uterine tone is diminished and uterus feels flaccid. Braxton Hicks contraction are not easily felt. So what happens, guys, is you do frequent per abdominal examination, and after that you feel what live uterus feels like and what intrauterine death wala uterus feel like. It feels flaccid and there is no tone in the uterus. So this is also one of the examination finding you look for. Third one is the fetal movements. Sometimes what happens is while you do per abdominal examination, you felt some fetal movements during examination, but in case of the IUD, that is not felt. So it's not like a hard and fast rule that if movements are not felt, it is a case of intrauterine fetal death. uh, it is incidental finding. Sometimes during examination the fetal movements are felt during per abdominal examination, and in case of live baby also there are chances that you don't feel fetal movements but baby is alive. Fourth one is the during fetal heart location on per abdominal examination you don't find fetal heart sounds. This is the most important finding. During the per abdominal examination, you don't find fetal art all over the abdomen. So sometimes what happens is, in case of the live baby, you also may not find fetal art sounds because various causes like polyhydramnios or obese patient, or sometimes if the environment is too noisy, you cannot find the fetal art. But in case of the IUD, surely you will not find the fetal art sounds. So this is one of the things that you look for per fetal art sound during per abdominal examination. Fifth one is the cardiotocography flat is trace. So if you attach the CTG like NST probe on abdomen of the mother, you see there is no any fetal cardiac activity is recorded. The other examination finding is egg shell crackling feel of the fetal head. This is the late feature, but sometimes you feel that. So these are the something. These are the points that you look for in case of the intrauterine fetal death. Now we move on to the investigation part. First and foremost investigation we do is the sonography. Ultrasonography is the earliest diagnosis possible. By ultrasonography, you can easily diagnose the intrauterine fetal death. In USG, we saw a lack of all fetal motions, including the cardiac activity, during a 10-minute period of careful observation with a real-time sonar. Also, sometimes the oligohydramnios and collapsed cranial bones are evident on the ultrasonography. Most common if the fetal art is not present during a 10-minute period of careful observation, then it is labeled as intrauterine death. Other investigation we can go for is the X-rays. X-rays we generally don't do nowadays, but there are some signs are uh, which we see in the X-rays. The first one is the Spalding sign, in which there is irregular overlapping of the cranial bones on one another is due to the liquefaction of the brain matter and softening of the ligamentous structures supporting the vault that usually appears 7 days after death. So what happens is, after 7 days the fetal heart after 7 days of the intrauterine fetal death, there is a liquefaction of the brain matter and the softening of the ligamentous structure that supports the vault. So there is overlapping of the cranial bones on X-ray, which is known as the Spalding sign. Other sign is hyperflexion of the spine. It is more common in some cases. Hyperflexion of the neck is also seen. It is also known as the ball sign. Ball sign. Another sign we see is the crowding of the ribs shadow, which is also known as the concertina effect. Concertina effect. It is known as the concertina effect, which is the crowding of the ribs shadow with loss of normal parallelism. Fourth one is the Robert sign. This is the first sign that appears during the intrauterine fetal death. What actually happens is, there is appearance of the gas shadow in the chambers of the heart and great vessels. It is but difficult to interpret, but this is the first sign that appears in case of the intrauterine fetal death. So some other blood examination we also do in case of the intrauterine fetal death to estimate the blood fibrinogen level and partial thromboplastin level periodically when fetus is retained more than for 2 weeks. So in case of the intrauterine fetal death, if the fetus is retained for more than 2 weeks, there are chances of the disseminated intravascular coagulation. So to rule out that, we have to estimate the blood fibrinogen level as well as partial thromboplastin level periodically. So there is recommended evaluation for a stillbirth. So if baby is delivered stillbirth, there are some recommended evaluation we have to do to rule out some causes why there is a death of the fetus inside the mother's uterus. So some routine examination we go for blood examination is CBC, ABO and RS blood grouping, Clear-Bedke test, VDRL, PP2BS, HbA1c, urea, creatine, thyroid profile, viral serology, lupus anticoagulant, anti-cardiolipin antibodies and thrombophila study. These lupus anticoagulant and anti-cardiolipin antibodies and thrombophila studies is more commonly done in case of the RPL. What is this? RPL is recurrent pregnancy loss, in which this lupus anticoagulant and cardiolipin and thrombophila studies are more important. We also go for urine examination for cast and pus cells. Thorough examination of the infant and placenta should be done. So after delivering of the baby, the infant and placenta should be look thoroughly for if you find some reason like too tight loops around too tight loops of the cord around neck. Sometimes you find meconium stained placenta or any other causes like skeletal abnormalities or anything else. So thorough examination of the infant and placenta should be done. As I said, the infant should be looked for malformation. We can also do skeletal Xrays for the same. Umbilical cord, that we look for entanglement, number of vessels. There are sometimes true knot of the umbilical cord, which can also lead to intrauterine fetal death due to this hampering in the blood supply to the fetus. Parental karyotyping should also be done in case of the recurrent pregnancy loss to rule out any balanced translocation. As I discussed, the placenta we should be examined for meconium staining, any malformation or respective weights are to be recorded. Autopsy and chromosomal studies are done for the fetuses and anomalies and dysmorphic features. It is also done if there is a history of recurrent stillbirth or if either parent is carrying balanced translocations. As I've discussed earlier, fetal skin, cartilage, and blood are usually taken for aneuploidy and single gene disorder study. For cytogenetic study, tissue must contain some viable cell. If there is no any viable cell, there is no cytogenetic study could be done. So this completes this diagnosis and evaluation for the fetal intrauterine fetal death. I hope you guys enjoyed my small lecture series. If you like this video, kindly like this video, share with your friend, and subscribe for more such kind of videos. And if you have any other recommendation how to improve this thing or any other topic that you want to learn next, you can also comment down below. Thank you so much.